Hi, everyone, and thank you for joining us today for the collision of the opioid and COVID-19 public health crises, an Ohio perspective. I'm Carol Dorn Sanders, Senior Vice President of Marketing and Communications for DisposeRx, and we are honored to be hosting this virtual discussion today. Our webinar, focusing on the state of Ohio, marks the start of a series of webinars we will be hosting to draw attention to states that have been severely impacted by the opioid epidemic and now the pandemic. And now let me introduce you to our moderator and panelist, Courtney Hunter, Vice President of State Policy for Shatterproof. Courtney, thank you so much for leading our webinar today and for all of the great work that you and Shatterproof are doing around the country. Thanks so much.
Thanks, Carol. It's so nice to be with all of you today. Thank you to DisposeRx for inviting Shatterproof to be a part of the discussion and to help facilitate, leading up to National Prescription Drug Take-Back Day on Saturday, October 24th. At Shatterproof, we are committed to reversing the addiction crisis in the U.S. We're working to eliminate barriers to addiction treatment access, increase training and education of healthcare professionals, enhance addiction treatment quality through our Atlas initiative, and reduce the stigma of addiction. We're also working with states to integrate behavioral healthcare and primary healthcare. So I'll be coming to you, Stan, for some questions about that in your FQHC work. We're really working to achieve a more equitable system for those in need of substance use disorder or mental health treatment. So just a little housekeeping. We have quite a bit of panelists to hear from, so there won't be any questions. So you just have to sit there and listen to me this entire time, okay? So to get us started, I just want to talk a little bit about the scope and the landscape and what we're seeing, in the U.S. and in particular in Ohio with regard to the opioid crisis. According to the Ohio Department of Health's mortality database, drug overdoses killed more Ohioans in May 2020 than any month in the last 14 years. A potential result of the collision of the opioid epidemic and the COVID-19 pandemic. Experts believe that the isolation, loneliness, lack of access to counseling and treatment, and financial hardships are contributing to those overdose deaths. We also saw this mirrored in some of the recent data released by the CDC, and also on a national level, the DEA's OD map showed an increase, about an 18% increase in fatal overdoses. But the opioid public health crisis is not new to Ohio. The state of Ohio and the federal government have committed hundreds of millions of dollars in recent years for treatment, recovery, and prevention efforts. Furthermore, healthcare organizations, corporations, nonprofits, coalitions, and individuals are engaged and helping to battle these colliding crises as well. Recovery Ohio, in particular, has done a tremendous job in increasing access to treatment and recovery support services across the state. So wanted to give them a shout out. And also wanted to thank State Rep Ginter for your leadership on the pharmacists bill allowing injectables for mental health and SUD medications, because that will really expand access as well. Today we have assembled a distinguished panel of guests who are working tirelessly to improve the lives of Ohioans by addressing addiction and the opioid crisis. So we look forward to hearing from all of your insights today, and we have a lot of questions. So with that, I will go ahead and just do introductions. Serving on the panel today are State Representative Tim Ginter from the 5th District of Ohio. Welcome. We have Nick Gonzalez, Health and Wellness Compliance Officer and Chief HIPAA Privacy Officer for the Kroger Corporation. We have Ernie Boyd, Executive Director of the Ohio Pharmacists Association. Miranda Williams, Director of Pharmacy Programs at the Ohio Bureau of Workers' Compensation. And Stan Jackson, Care Manager of Addiction Services at Health Source of Ohio, a federally qualified health center. So I'm going to ask each panelist a question. I'd like to start with you, State Rep Ginter. State budgets have suffered tremendously as a result of the pandemic. How are legislators and the executive branch of the state of Ohio working together to address the opioid epidemic during COVID-19?
Well, I think right now thank you, Courtney, for the question. Right now, what is taking place is, as is happening with a lot of organizations around the United States, there is a regathering, and there is, so to speak, going back to the drawing table. And we've been doing that even as early as this morning. I've been meeting with individuals in regards to the state budget, talking with them on Zoom calls such as this, and prioritizing legislation and those items that we need to focus upon in moving forward. I think your introductory remarks in regards to the increase in opioid overdoses and the other measures and metrics that measure our society's health in general have been brought to the attention of the legislature. We're certainly going to work as leadership on focusing finances where it's going to be needed. And you're absolutely correct. We've already been told that this will probably be one of the most challenging state budgets that we've ever faced. However, the tax revenue that has come in recently, those numbers, and we're continuing to watch those, have been somewhat encouraging. And the sales of homes and the sales, for example, of cars, real estate sales have been perhaps surprising to us in light of what we anticipated with the COVID-19. So with all of that in mind, I want to assure everybody who's watching this that our priorities still remain in place. And one of the highest priorities, I know as I speak on behalf of our other legislators, is that the battling the drug epidemic in the state of Ohio is a very, very high priority.
I appreciate that. And something that keeps me up at night is looking at the tobacco settlement and how only 2 to 3% of those dollars were actually spent on prevention and cessation programs. With the forthcoming Ohio MDL, the multi-district litigation, and the new One Ohio agreement, how are you, looking at that in terms of funneling and allocating those funds to the right resources in the state of Ohio?
Well, to be frank with you, that is somewhat out of my bailiwick at this point, but I can tell you that our finance chair and the finance committee is focusing upon that. Chairman Oslager is looking at that very closely and recognizing that, as you just said, some of the shortfalls of those missing those goals that we were looking at. But I can't speak on his behalf, but I'm sure that, again, as that is brought to our attention, those things, there will be adjustments made in the course and in the approach as we move forward.
Sure. Ohio has been such a leader on that front with the One Ohio agreement, and the governor, really coordinating all of those efforts. Are there lessons there for other states?
Absolutely. And I think that the cooperation, and of course, we give great credit to the governor and his staff for moving forward with the One Ohio. And I think that other states do look, of course, we do look at each other. States do check with other states to see what they're doing that has been particularly effective and impressive. And I think the One Ohio in particular has been a tremendous example to other states as to what can be done. And so we commend the governor for that. I'm not sure what other states have been taking a look at it, but I can tell you even this morning on another phone call, we were looking at another subject that I won't bring up here because it has to do with tax structure. But even in that call, we were discussing what other states have done in regards to their tax structure. So I do believe that that is a model for other states to take a look at, and again, commend the governor for his move on that.
Oh, thank you for that. You mentioned that your priorities remain the same. Can you talk a little bit about what are the state's priorities with regard to the opioid crisis and what you're looking at investing in moving forward?
Well, the priorities have been, and I believe will continue to be, that we make sure that there's accessibility to treatment. And that was, of course, one of the main goals of when I was approached about House Bill 341, was that I was interested not only in providing accessibility to what I would consider cutting edge treatments. I had to learn agonist, antagonist, partial agonist. There was a lot of new language that I had to learn as that bill moved forward. But I think one of the main, as you have already mentioned, one of the main things that was accomplished with that bill was allowing our pharmacists to administer the long-acting extended release addiction treatment drugs and not just limiting them to opioid antagonists. And so that opened the door for us to get treatments to those individuals that are needing it. We also, as you well know, and I don't want to dwell too much on 341, but we also dealt with the, we removed the exemption requirements for the Cat 3 licenses since it was direct administration. And we tweaked a little bit of the open meeting exemption to allow the Board of Pharmacy to utilize conference calls if there was an emergency that came up in regards to the suspension of a license. And then we allowed ORs, the information of ORs for prescriber pharmacists to communicate with the Department of Defense so that those individuals who served, for an example, in our armed forces would be able to receive access, and we'd be able to share that information so that they receive treatment. So 341 is somewhat of a model as to the priorities of the state of Ohio. I think that, first of all, we need to focus upon the treatment, the accessibility of treatment for those individuals. We need to make sure that they are properly funded, that those treatment centers are properly funded, that they're receiving the means that are necessary. And I have also a meeting a little bit later with a counseling service, a statewide counseling service, because we want to make sure that all areas of this epidemic are addressed. Other than that, I'd be happy to answer any, maybe a direct question in regards to some certain area, but by and large, I have found that as I testified before the House, I testified before the Senate, of course, the speed at which the governor signed this bill and his remarks concerning it, we place very high regard on emphasizing that which we can do, even financially. It's right up there near the top in regards to our priorities.
We appreciate that leadership and investment and focus and that sense of urgency. So thank you for your reflections on that. I'm going to pivot a little bit and head over to Nick. I want to give our other panelists a few moments to speak as well, and would love to just make this more of a dialogue. So let me know if you'd like to weigh in on a question as well. So Nick, I know that Kroger has invested tremendously in its opioid stewardship program, I believe across your 3,000 stores. Can you share more about those initiatives, the opioid stewardship initiatives, and also any consumer education programs that you're working on?
Yes, I can. Thank you, Courtney. I want to say thank you to you and thank you to DisposeRx for putting this on today. At Kroger, we have been really invested in how do we help curb the opioid epidemic. Our purpose is to feed the human spirit, and at Kroger Health, our vision is to help people live healthier lives. And really everything that we do goes back to how are we achieving those goals. As far as what we've done from a opioid stewardship program is we were the first chain pharmacy to have the prescription drug monitoring program in workflow, meaning that states set up prescription drug monitoring programs to allow pharmacists to look at drug information about people coming in to help counsel those patients. And we put it in workflow so that our pharmacists didn't have to go out to another website to obtain that information. So our pharmacists are able to do that in 26 states that have a feed in about 1,753 pharmacies, including Ohio. The stewardship then we really got into naloxone and making sure that that drug was available for everyone, and we dispense it without a prescription where we're allowed to. And we've even had pharmacists in our stores who have had to help administer naloxone to someone that may experience a overdose in one of our restrooms. We've been you mentioned at the beginning, the drug take back. We've been very involved in that and excited to participate again this coming weekend. In the last few months, we've collected well over 12 tons of unwanted medications. But as you talk about what we're doing as far as education, I think this is something that we're very proud about. We've partnered with EverFi, and we offer free online education for high school students in certain markets to learn more about prescription drug use. And when we saw the success of that program, we said we have to do something more. Rodney McMullen, our CEO, signed the Lidl's Pledge. And as we started evaluating that, we said, you know what, we're leaving out our associates and we're leaving out adults. So over the course of about the last year, we worked with EverFi to develop modules for adults, and they're free of charge to anyone. You can go to the krogerhealth.com website and find a link to the modules there. But the modules talk about different things that adults may find interesting for opioids. It starts off with our commitment to addressing the opioid epidemic. It has a module, and the modules are 3 to 6 minutes in length, and you can come and do them at your own pace, but about storage and disposal of prescription medications, how to properly dispose of those using things like DisposeRx or drug take back, recognizing the signs of opioid use disorder and responding to an overdose. What steps should you take there? Supporting friends and family suffering from opioid use disorder. What resources are available to you? How can you help support your friends? How can you get involved in the community? Understanding a little bit more about opioids, the facts about them, just their makeup and some of, at times, their addictive qualities there. We have a simulation in there for refusal skills. And this is something that we borrowed from the high school module. Is we found a lot of people had a hard time saying no to people. And you have to put them in situations where they'd have to say no. In the high school module, it's basically someone comes up to you and says, hey, Nick, I know that you had your wisdom teeth out. I hurt my back at basketball practice. How do you say no to that, your friend, to say, I can't give you my prescription medication. I'm not being your friend by giving you that. And actually, it could be quite dangerous. And getting past that, just because they're a prescription drug, that they're safe for everyone in every situation. Obviously, they have their role and they serve a very good purpose. But we need to, just because something is a prescription doesn't mean it's safe for everyone at every time. Some of the modules are having a conversation with your teen. We found that adults sometimes don't know how to talk to their teenager about opioid use disorder and what their child may be experiencing at high school. We have in there opioid alternatives. What alternative medications might be good instead of an opioid? Reading and understanding a prescription drug bottle label. While it may be common sense to everyone on this call or on this webinar how to read that, we found that in research, they found that people, if you said take twice daily for pain, a lot of people thought that meant take twice daily. But it's only take twice daily if you are in pain. And just understanding some of those nuances of how to do that. And then the last one was just about opioid misuse in general. We just launched these a few weeks ago. We'll be promoting them obviously during Drug Take Back, trying to get people to go there, but we want to make sure that people are aware of this free resource that's available online to help better understand more about opioid stewardship.
That's really exciting, especially at a time when everything is virtual and we really need virtual programs to educate parents and consumers, and especially when parents are also looking for things to share with their children if they're homeschooling or in a virtual environment. So look forward to hearing and hopefully seeing more of that in the future. And just thank you to Kroger for your investment also. I cannot stress enough how important it is that we have corporations, nonprofits, elected officials, health centers, kind of everyone at the table here to invest in this space. it is only, it's the only way that we can really fight this battle. So appreciate that. And I'm going to turn it over to Ernie now. I want to ask Ernie a question about pharmacies, kind of tagging on to what you were sharing. Pharmacies and pharmacists, Ernie, are on the front line of both of these public health crises, the opioid crisis and also COVID-19. I guess October is American Pharmacist Month, so happy American Pharmacist Month. We want to thank all of you for everything you're doing to keep us and Ohioans safe. And just want to ask you, Ernie, what is top of mind of the pharmacists you represent during these challenging times as their roles in the care of patients continue to expand and the need is greater?
Well, first I want to thank SposeRx and Carol and you for having us. The top of mind things really have to do with a lot of things that Representative Ginter and the legislature have passed in the last 3 years. I do thank him very much on the long-acting injectables. We're now doing lots of training in my office. I believe even today we're doing training on injectables. And that has given us the ability to save lives, literally. That legislation, part of it, the piece that had to do with long-acting injectables, came about because a young man couldn't get his naltrexone on a weekend, committed suicide after that. And so there was a recognition that, he couldn't get into the physician office, but there were plenty of pharmacies available had they been able to take care of the scenario. Pharmacists are implementing many of the things that the legislature has passed in the last 3 years, such as expanded consult agreements where pharmacists can actually prescribe in a limited manner in a consult agreement with a physician. And that comes into play with sometimes with substance abuse, sometimes with diabetes, other kinds of things. But pharmacists are beginning to finally act at the top of their license. The other thing the legislature has been very helpful on is putting pressure on the pharmacy benefit managers and on Medicaid to pay our pharmacies enough to stay open. We've lost over 300 independent pharmacies over the past few years. And it was discovered that pharmacies were so badly underpaid that the state is billing some of the PBMs is expected to millions of dollars. Now what's happening is the managed care organizations are meeting with, there are 5 of them with Medicaid, and they've been meeting with me and my staff and pharmacists over the last year and a half since hearings were held in the House Finance Committee, where President of CareSource and the other programs said that they were going to work to implement pharmacists as providers. Now, what that means in a nutshell is that pharmacists now are being paid for slowing down and talking to the patient. Why? Because 55% of patients take their medications incorrectly. 55% results in 10% of all hospitalizations, 20% of all nursing home admissions are purely because they got the right drug at the right time, but they didn't take it properly. Now we're working with the patient. One of the best things we do is to look at 12 meds, figure out that 3 of them shouldn't be currently in their mix, call the different physicians, there might be 4 physicians involved, and get rid of those 3 meds. Well, in the old days, we would actually lose money in that scenario, right? Because we spent time on the phone. And in this COVID scenario especially, we're finding that not as many prescriptions are being filled. Why? Because people aren't going to the physician as they should. The feds have figured out that parents are not getting their kids in for their vaccines. And so now HHS has overridden a lot of state law and has said, pharmacists, you are now authorized to administer to children under age 7, whereas in Ohio, we were not allowed to. And the reason for that is that a lot of these kids are missing their vaccines. We now are allowed to be in the children, the VFC program, the Vaccines for Children program in Ohio. So there's a lot of changes that pharmacists are taking a greater role. With the COVID specifically, we now have pharmacies doing testing. We have pharmacies. When the vaccine comes out, we've been in touch. Matter of fact, I've got a webinar tomorrow where we're going to be learning about how pharmacists are going to get access to whatever vaccines become publicly available. Pharmacists are going to be administering the vaccines to the patients in nursing homes in the near future. So the good news is we're being utilized a lot more, and to have an insurance executive sit down with me at lunch about 4 months ago and say, because I asked him, I said, what's going on really? Why are you finally doing what we've asked for 20 years, which is to pay us for what we know and for how we can educate the patient? And he said, because we have recognized that pharmacists know their patients better than any other provider. They realize that a number of people go through our doors every week. When you look at Nick's Kroger stores and all the others, a number of people equivalent to the population of Ohio go through our doors every week. And so they want to take advantage of that. So at the end of the day, we're very pleased that pharmacists are helping. And as Nick mentioned, not only in the bathroom there at Kroger, but we had a Walgreens pharmacist go out on the street in front of their store a few months ago and save somebody's life with naloxone, Narcan. And so we're doing our best to be an active part of the healthcare team, and we're glad finally insurance companies are recognizing that.
That's wonderful. Such amazing updates, Ernie. And I cannot agree with you more. The importance of the role of pharmacists, particularly in this pandemic, where we're seeing clinic closures, we're seeing people not, accessing healthcare, not going to their provider because of fear of either catching the virus, or also the stigma related to getting treatment when you have SUD. Whereas if you can go to the pharmacy, there's a lot less stigma associated with that than going into, a methadone clinic, for example. So a huge role to play. And I'm going to have more questions for you in a little bit. I find that fascinating. 55% of people take their prescriptions incorrectly. So there's definitely some misuse and abuse potentially within that 55% as well, or maybe it's just, misinformed, right? So thank you for everything you're doing. Miranda, we know that the Bureau of Workers' Compensation is certainly concerned about the impact of opioids on patients as well, employers and the state. What are some of the programs or projects that you have initiated to educate injured workers about their opioid prescriptions and the risks associated? And would also love to hear if you're working on anything around opioid alternatives, because I think that's another thing that we've talked a little bit about in this webinar today, and has been a theme is as we head into Take Back Day, what are the alternatives available? Do we need all of these, opioids for pain management? So Miranda, sorry, that was a big question.
No, that's okay. Yeah, sure. I'll just start with, some of the things that we're doing here at BWC, both around education, but also, prevention, and preventing the opioid epidemic from becoming worse. First I'll start with, when our pharmacy program was actually implemented, and it was established about a decade ago, the first thing we did was we created a closed formulary for injured workers. And the formulary does a few things, but specific to opioids, we limit injured workers' reimbursement to one short-acting opioid and one long-acting opioid. They can't get more than one short-acting opioid. It also restricts the number of daily opioid doses we'll reimburse for. So we will only pay for up to 6 tablets a day. We don't pay for 10, 12, no more than 6. It also adds some prior authorization requirements for higher potency and long-acting opioids. For example, fentanyl, methadone, oxymorphone. Before we will reimburse for prescriptions for those, we have to review the claim and ensure that it's appropriate and necessary. We also established in the formulary that, post-operatively, we do not reimburse for long-acting opioids unless they were taking a long-acting opioid before their surgery. So these are just some examples of what's within our formulary, but really all of these limitations that we put in place are what we know are best practices. And we are translating those best practices into our reimbursement rules to make sure that injured workers are receiving appropriate care. And we use, I also wanted to mention, naloxone that is on our formulary, and we use something called a smart edit, which means that when an injured worker goes to a pharmacy, if they filled an opioid, they can also get naloxone from the pharmacist, and we will reimburse for that. And they don't have to ask for a prior authorization. Sometimes that's a barrier to individuals getting naloxone to prevent an opioid overdose. So we're trying to also use technology, to make things easier as far as like naloxone goes and other drugs that are used to treat substance misuse disorders. Aside from the formulary, we're also working to educate our providers to make sure that they are applying best practices. Specifically, we adopted a rule in Ohio Administrative Code. The rule is 4123-6-21.7, and it outlines the documentation requirements that have to be present in an injured worker's claim in order for us to reimburse for opioids. It specifies that if opioid prescribing goes over a certain dose or beyond 6 weeks from the date of injury, the doctor must be documenting best practices. And by best practices, what I mean is what the medical board has outlined as appropriate opioid prescribing. And we actually refer to the Ohio Medical Board rules within our reimbursement rules. Just, for reference, some of these best practices are things like having a documented treatment plan, performing a risk assessment before you prescribe opioids, getting informed consent from the patient, and having a written pain agreement with the patient. And I won't read the entire list to you, but I just wanted to give you an idea of what the requirements look like. They really are just best practices that we would expect to be applied to a situation where dangerous drugs are prescribed. And since that rule was adopted, our pharmacy department has actually been reviewing every single injury claim to make sure these best practices are followed. And if they're not, our nurses actually reach out to the providers personally on the phone and then follow up through fax and explain that they're not following the rules. And we alert them to what is missing. And then we request that they either provide the missing documentation or they taper off the opioids. And we will try to work with the provider. We will reach out with them 3 times before ultimately reimbursement for opioids is impacted. And I just wanted to highlight this rule and what we're doing with it because, we're really putting forth a lot of effort to ensure that our providers know what the best practices are and that they're treating injured workers accordingly. And along those same lines, we're also participating in a research study right now with Ohio State University, University of Washington, and Washington Labor and Industries to study the impact of our opioid policies, both on the prescribing providers and the patients, and then on prescribing patterns within Ohio. So research like that's important. We can determine the efficacy of some of these policies and help inform other states on what works and what does not work. And then, of course, last but not least, why we're all here today, I just wanted to talk about our drug disposal program. Last year, Governor Mike DeWine announced that BWC would begin to offer reimbursement for drug disposal products for injured workers who fill a new opioid prescription. So if an injured worker is presenting to the pharmacy with an opioid prescription and they hadn't taken an opioid in the year prior, they will be eligible for one of these products. And we feel that this is an important group to target because it's possible, very possible, that when someone gets an opioid, either post-op or for acute pain, they were maybe just injured, that they don't finish all of their opioids in the bottle. And then those opioids end up sitting in medicine cabinets or drawers, and they're just ripe for someone to get a hold of and misuse them. So we're not only trying to reduce inappropriate opioid prescribing, but we're also trying to address what happens to the leftover opioids if somebody doesn't finish their entire prescription. And we want injured workers to get rid of the leftover opioids as soon as possible. We know that our pharmacies have been very generous. They have drug disposal, locations on site. But we also want to provide this opportunity where they can safely dispose of them at home, that they don't have to wait until the next time they're going to be in the pharmacy or near a disposal location to get rid of them. Through this program, again, we're trying to, use technology as much as we can to help make this simple. So when an injured worker takes an opioid prescription to the pharmacy is actually alerted through messaging on the computer that the injured worker should be offered a disposal product. And then at that time, the pharmacy has the opportunity to offer the product to the patient and bill BWC for the disposal product. And then we would reimburse the pharmacy for their cost of providing the service. Like Nicholas said, a lot of pharmacies, including Kroger, this is something that they do for free because, pharmacists are just caring people. We want to make sure that we, offer safe opioid disposal. But we also feel, if we are reimbursing for those opioids, we should also cover the cost of making sure they're disposed of safely. So those are some of the programs that, we've developed at BWC right now. Of course, this isn't, I wish I could go into more detail, but I'd be here all day talking. So if anybody has any questions and is interested in any of these programs, I'm happy to talk about them in more detail.
No, it's such an important role that you all play as well. And I just have a question related to the limiting and restrictions of opioids. Are you working to encourage alternatives for any workers that are in pain, and what are you prioritizing?
Sure. Our formulary offers coverage for numerous non-opioid alternatives. And through our medical side, not within the pharmacy department, they deal with reimbursement for other services. We've reimbursed for things like acupuncture, chiropractic care, physical therapy, lots of not even just non-opioid, but also non-pharmacologic care. Excuse me. Because we don't want people to end up using opioids chronically. Yes, and then within the formulary, we have, of course, non-steroidal anti-inflammatory drugs. We have topical medications, anything you could imagine that's not opioid that's on the market that's effective for pain. We are certainly encouraging that. Just last June, we removed OxyContin from our formulary. We do not have any injured workers currently taking OxyContin at this point in time. Instead, we are encouraging the use of what's called abuse deterrent formulations. At the same time, we added Xtampza to the formulary. So abuse deterrent formulation doesn't necessarily mean that the drug cannot be abused, but it is more difficult to abuse. You can't crush it up. You can't melt it. It definitely discourages misuse and diversion.
Sure. And I'm actually not sure why they're all not abuse deterrent at this point in time. But that's a pickle for the FDA for another day. That's so helpful to know about the non-opioid alternatives, and also something you touched on with regard to naloxone and covering that kind of harkens back to what Ernie was and actually Nick were both discussing about co-prescribing naloxone and opioids, and the Surgeon General has made a big push for this in recent years, and would love to just raise the flag about that, and keep letting people know that you can co-prescribe both of those, especially if they're covered, just to prevent any unintended overdose. So thank you. Let's head over to Stan. I want to get you in this conversation. Stan, we're so excited to hear about what you're working on at your Federally Qualified Health Center, or FQHC, and the care that you're providing to communities, making access to healthcare possible for so many who would go without healthcare or would end up in emergency rooms. So can you talk with us about the addiction services that you provide at HealthSource and what you've been seeing, particularly in the last 7 to 8 months since the COVID-19 pandemic hit?
Sure. So first off, I want to say thanks to DisposeRx for including Health Source, including Health Source on this discussion. So I've been with Health Source for about 2.5 years. And when I came aboard, the organization was moving in the direction of integrating primary care with behavioral health. So my role is to basically be that bridge for our patients. Being a former AOD counselor, I'm very familiar with the field and with this very specific population that we deal with. So being that bridge is basically to get the patients into treatment. And also support. That's a big thing as well, because a lot of patients don't really have that support, whether it be from their family, whether it be from their friends. So they're kind of alone in a lot of different ways. So I just really try to build that rapport and just let them know that, hey, you do have Health Source, you do have me for guidance and support and direction. Because a lot of times they don't know, they've never been in treatment, so they don't know what to expect. So that's another opportunity for me to kind of explain that. So when the patient comes to his or her appointment and if services are needed or maybe needed, a referral is then placed to me. I'm the only one in this role at the moment with Health Source, so it's a pretty big role. Imagine covering 8 counties. We cover 8 counties in the state of Ohio, so it's a lot of ground to cover and a lot of moving pieces. So once the referral is placed, I then proceed to contact the patient to begin that dialogue. A lot of MI or motivational interviewing is used, but my first goal is to build that rapport. Because basically I'm a stranger to them. I'm calling them out the blue. They don't know, really what to expect, and they're nervous. It's a lot of anxiety that's being built up. So I just try to first build that rapport, because without that, guess what? They're not going to talk. They're not going to speak with me. They're going to basically shut down. And then that's a missed opportunity for me to provide that service for them. So a lot of times I hit, but a lot of times I also miss. So that's primarily because the patient may be on the fence or feel like they don't need help. And you will run into that a lot of times. Patient may say, they may tell the provider one thing, and then when I speak with them or a nurse speak with them or a MA speak with them, they're getting a whole lot of different stories. So you get that a lot as well. If you talk to 4 different people, a lot of times you're going to get 3 or 4 different answers. And that's just the nature. That's just the nature of the beast. So basically it's meeting the patient where they're at. And I say that a lot because it's true. You really have to meet that patient where they're at. And you can't be forceful when it comes to stuff like this, because it's a very sensitive topic to discuss. And someone mentioned stigma earlier, and that plays a big part of it as well. And so really, so when I meet the patient, I'll call them on the phone, or I can meet them at their appointment. And that's a really good opportunity as well, because I get to see them face to face. But often that's really not the case, because the staff won't know there's an issue until they actually make their appointment, or they're actually in the practice seeing the staff. So the process will remain the same, regardless if I meet the patient at their appointment or I happen to contact them via telephone. I'll give them some options. I'll first explain how program works, how medication works, because there's a lot of questions that they may have or their family members may have. I've run into that a lot, where there's a mom or there's a concerned parent that's really interested in the program, but they don't know anything about it. So they want to make sure that they have information as well to kind of help their son or their daughter once that journey begins.
Stan, sorry to interrupt, just a quick
Sure.
question on that.
Sure.
When you come into the picture, has the patient screened positive for SUD or MH, and they're seeing you after a primary care provider?
Most times, yes, they will be introduced to me after the fact. So we have different screening questions that we ask, and either they will kind of draw some red flags on those screening questions, or B, the patient may just come out and say, I've got an issue with substance abuse, or I got an issue with alcohol. So it really kind of depends. If they come out and say that, then that makes the process a lot easier for the staff and as me as well. If they test, if there's red flags on those questions, then again, that's where that motivational interviewing needs to kind of come in place to kind of push them in the right direction. So
you are speaking my language right now. Screening, motivational interviewing. I love it.
Yes.
We are so focused on collaborative care, and this whole idea of integration is really big right now. So what you're doing, I don't think everyone knows how critically important this is, how much money it saves, and how good the outcomes are. So I'm really jazzed about everything you're doing. About 80% of patients who need behavioral health care treatment are seeking it in a primary care setting, but they're not going to specialists. And so that's where you come in and really help with that. Sorry, I don't mean to steal your thunder. I'm just
no, you're fine.
But Ohio is not one of the states that's covering the collaborative care codes within Medicaid. So you and I should huddle about that.
Cool.
So what else have you seen? Have you, since the pandemic hit, since COVID, are you seeing less patients because they're afraid of catching the virus, or what does that look like for you in your role?
Actually, I want to say it may have slowed a little bit once the pandemic started, but now it's kind of it's really picked up. I will say that it has picked up a lot, and of course, patients weren't being seen, so that's missed opportunities there. The good thing is that most programs were still up and running, and they were still seeing patients, whether it's face to face or limited face to face, or via Zoom. But I probably would say maybe 60 to 70% of the referrals that I've gotten were for alcohol. And the numbers have shown that since this pandemic, alcohol sales have increased. So it's no wonder, that a lot of the patients that have been referred to me have been dealing with alcohol abuse. And that may have been stemming from years prior, or just something that kind of came about now. But that's a lot of what I've been seeing is alcohol use.
That's so interesting, and really correlates with what I'm hearing too from other folks, and just what we know, right, about economic recessions and times of financial hardship. People, the numbers in terms of alcohol use disorder, suicide, depression, and mental illness, behavioral health issues are on the rise. And so we really need to be cognizant of that, and continue sounding the alarm, and continue doing all the hard work that we're doing. Thank you. So, and this is really open to anyone. Want to ask about, in Ohio, where do you feel like there are gaps? Whether that's with funding or access to treatment, or educational resources. And maybe we'll go back to State Rep Ginter to get you back in. Would love your response to this question first, and then we can call on other folks as well.
Sure. So I did fail to mention a couple of things. When we consider the subject, and by the way, thanks to DisposeRx for this this discussion and this opportunity to get together and discuss this very important issue. When we consider the breadth of how addiction impacts our society, and we consider how it impacts the whole state, it impacts so many different areas. And what I failed to say earlier, Courtney, was that when we look at this as legislators, or I should say, as I look at it myself as a legislator, sometimes I'm very focused, for example, as I was on 341. Other times I've been focused upon other issues, such as for a short time, I carried a bill that would that was projecting the use of tamper-evident pill containers, because in the research, as you've already brought out here, and DisposeRx is very well aware of, it was alarming to me how many of those who struggle with addiction pointed back to the fact that they took their first pill from a family member's. They got into the medicine cabinet, they took their first pill from some type of drug that a member was taking, or perhaps had been there for years and had just forgotten about. And it brought them down, it took them down that pathway to addiction. So sometimes I'm very focused in that area, but at other times we have to turn our focus into some other areas that also are being impacted and have an impact as far as bringing recovery to individuals in the state of Ohio. For example, I think that one of those areas is criminal justice reform, and the fact that we need to take a hard look. And SB 3, if you're familiar with that, Senate Bill 3 is taking a hard look at some of adjusting some of those penalties that are currently leveled against individuals that are caught up in the web of addiction, and where we need to make changes. And SB 3 is trying to do that. I believe has made an effort to do so. Is that we need to differentiate between punishing those who are very dangerous and those who are dangerous to society, dangerous to those who are struggling with addictions, and then but providing treatment opportunities for those individuals that are suffering from addiction. So rather than grouping them all together in our penal institutions and putting them all together, and then finding out that those individuals who are in prison, where we've grouped them in, that were non-dangerous individuals, sometimes first-time offenders, they come out actually in worse condition than they went in. And so we need to make sure that with criminal justice reform, we are truly trying to bring the help that is needed to those individuals that need treatment, not necessarily needing punishment. And so that's an area that we're working on. And just an example, and I don't want to take up too much more of the panel's time, but it's just an example of the wide breadth of subjects that we deal with in the legislature because of the impact that this has upon our society, upon families, and upon the whole state. So I don't know if that answers your question, but
yes. Well, and something I've seen, you just reminded me of something that I wanted to ask about as well, with drug-induced homicide laws. And I think Ohio was recently highlighted for, utilizing those to bring people into the criminal justice system. And just curious on your take on that, and if that's something that's being looked at within the legislation that you mentioned.
It is not. I do not believe that is a part of the language of SB 3. And again, that is coming over to the House from the Senate. And we currently, I think we're up to bill number 770 some right now. So it's very difficult for us to keep track and keep things on our screen. But in regards, I think you're referring to individuals that can you help me with that, Courtney? Is that regarding individuals who had committed homicide in regards to a drug offense, or they were under the influence of drugs?
So drug-induced homicide laws are prosecuting those individuals who have given drugs or shared drugs with somebody who then overdosed. And those individuals who are sharing them are not necessarily dealers, right? They could be friends, they could be spouses. And there have been some instances of states utilizing state opioid response grants for their criminal justice system to help prosecute those individuals. And I'm sure this is like one part of the story, and so that's really why I want your input and how this is actually happening on the ground, and how we can help get those people into treatment when it's the right case by case situation.
Mhm. I do not serve on criminal justice nor the judicial committee, and so sometimes these bills get fairly long into the process before I become aware of them. So right now, I need to make a note on that because I'll confess to you, I'm not really sure.
No problem. Oh, I stumped you.
Yeah, you did.
No, not at all. Thank you for that. I look forward to following up with you on that.
Thank you.
So I know we're nearing kind of the end of our panel. I just want to ask, does anybody else want to talk about gaps that you're seeing in the state, or something that you feel is needed in Ohio? I know it's an incredibly urgent time and desperate time for a lot of people, and so want to just point to any other resources that you might need in the state that we can help elevate. How about, I'm going to call on somebody. Nick.
No, I think Miranda talked about it. I think it is about some of these at-home solutions and some of the reimbursement there from various programs to cover at-home disposal. We know that over 50% of people, the first time that they take opioids is from a friend or family member's medicine cabinet. So how do we reduce that? And especially during this time of social distancing and everything else, you're around your medicine cabinets, you're at home and everything else. It's a very difficult time period for people in their lives. And how do we remove this temptation for them? And I think offering things such as at-home drug disposal, having a little bit of reimbursement there to make it net neutral. DisposeRx has done a great job here. We're happy to supply it on certain opioid prescriptions free of charge, but I think that's a great way that we can continue to combat the opioid epidemic.
No, absolutely. And leading up to Take Back Day on Saturday, October 24th, I think it's a good reminder that we can all do our part. And thank you for your leadership on that front. It's really important to get rid of those medications. We have way too many unwanted prescriptions, and they can put people at risk for sure. So that's an important reminder. And I just wanted to offer my 2 cents in terms of a gap. I come from the prevention world a little bit and worked at Partnership for Drug-Free America for a long time. And, we've just seen prevention funding get slashed over the last 20 years. And then everyone says, why do we have a problem? Well, because we stopped preventing use. And so I would say, I think we need everything. We need a comprehensive solution, no silver bullet, but we really need to invest in prevention and preventative solutions and education for our young people as well. We know that 90% of addiction begins in the teenage years. So there has been, a lack of investment on that front and really moving away from that. And that's an important tool that we have to help combat the disease of addiction moving forward. Are there any other activities or programs that are going on related to Take Back that anyone wanted to highlight that I neglected to mention?
I just wanted to speak up, Courtney, and say, with this whole reimbursement for drug take back to pharmacists, we were really kind of pioneering this idea. How do we do it? We've sat down actually with Kroger and numerous other pharmacies to really iron out and nail down, like, what's the best way for an insurer to cover these types of services without being overly burdensome, to the pharmacies that are already crunched for time, with all of the prescriptions that they have to fill. So I just wanted to put out there that if there's anybody that is interested in how do you do it, what's the best way to do it, I'm happy to, share what we have learned about how do you effectively implement something like this?
Have you shared that, Miranda, with other states in terms of workers' comps groups or any coalitions? Because that does seem like such an innovative thing that it could be a model for other states with their BWCs.
We have not shared to date because we are still perfecting the model. We're actually implementing an enhancement currently to that. But I feel like we're arriving finally to a product that works for everybody. And yeah, like you said, I think that's a great idea to, put out a guide and make it easy. This is something that we should all, collaborate together on.
I would love to put you in touch with the National Association of Home Builders. And they could be a good partner for something like that and getting that, out to other states. And maybe that's why I'm on this call as a panelist, because I'm not a panelist, but a moderator, because I'm from a national nonprofit, and I can help hopefully spread the word about all the good work that you're doing in Ohio collectively, and in such a comprehensive way that we can, share as a model for other states, and help other states. I think particularly in this time where people aren't going to conferences, we are sharing, but we're not really sharing as much. And we're also just kind of trying to keep all of our heads above water. So the more that we can share what's working and not having to reinvent the wheel is good stuff. So thank you for sharing that, Miranda. Thank you to all of our wonderful panelists. This has been such a good discussion. I hope that you feel like you got something out of this. If I certainly did, just meeting all of you. So thank you. Carol, should I hand it back over to you?
Perfect. Thank you so much. It was such a rich discussion. I think we all learned so much and have facts and figures that we can take back to work. And I love the collaboration. I love the good ideas. And I do think Ohio is a great model. And this is, as I mentioned earlier, the beginning of a series for us. We're thinking it'll probably be 4 or 5 states that we will do something similar. We're working on Kentucky next for November, and then we'll go into the new year. So William, our president of DisposeRx, would you like to say a couple words real quick before we wrap up?
Sure. Thank you. So first of all, thank you, everybody. This was a great discussion. Courtney, thank you for doing your part and the great work that you do with your associations. And Carol, thank you for pulling this together. This is quite something. We are very committed. We've got a very passionate team to solving a very big problem. Everyone here has got some great points that I just appreciate conversations like this. This is how we solve problems as a community is we get together and we continue to talk. And, we try to remember every day that we're talking about our neighbors, our friends, our family, our community. We're talking about our humanity, and these are things that we can do to help each other. I think Courtney, you'd said it. We all have to do our part. There is no silver bullet. It's the work that Stan, that you're doing, Nick. Our focus is pharmacies. We love working with our pharmacies. We love working with payers. We love the process that we're doing, and really, I appreciate everybody coming together. Carol, this is a great conversation, and I hope that we can continue these conversations, because I will guarantee you that we as a team are very dedicated and passionate to making some big changes in 2021. I think we can all hope for some changes in 2021, and if we can keep moving the needle on this conversation, we'll think that that's a big win for all of us. So thank you.
Great. Thanks, everyone. Take care and stay safe.
Thank you.
Thank you. Have a good afternoon.
Thank you.